Hello students, my name is Liz Attia and today's topic is principle-based ethics, autonomy and informed consent. Okay, so principle-based ethics, autonomy and informed consent. So the process of consent involves a competent and informed patient expressing their autonomy by either giving or refusing consent to the treatment suggested by their therapists. So informed consent also actually means a lack of consent or refusal to give consent. But that's not always the case. Let's consider this. There are two elements to enable valid consent, and this is actually in your textbook, and I'd ask you to go back and actually make sure that you highlight those and take note of what they are in your readings. There are two elements to inform a patient as well. So there are two elements to enable valid consent and two elements that go to information of patient consent. So I'll just leave that with you for the moment and we'll come back to it. But noting that, there are also some conditions as to what constitutes informed consent and what constitutes consent under the law. Consent cannot be general. It must be specific, both in terms of the procedure and in terms of the practitioner or the professional who's given the consent to actually undertake the intervention or the action. It also is based on veracity, the duty of truthfulness by the health professionals, that the information that's been presented to the client or to the patient is free of misinformation, mistruths and inaccuracies. In terms of how you gain consent, that also becomes important, and we go back and we actually talk about this in a few slides' time. Now, just before we actually move on, I do need to point out to you that individuals must be mentally competent to make their choices. And this has both legal significance as well as ethical significance. And there are standards for assessing patients' competence. So you'll find that different health professionals will have their protocols and regulations about how to actually assess the competence of patients. And that's why sometimes you actually see health professionals will ask clients, what date is it? What year is it? Can you tell me your name? Where do you actually live? And it's to assess that in the moment they're actually in possession of their mental faculties and that they're actually able to understand information which is being given to them. But it raises the question as to who should actually be allowed to make these assessments, because clearly there's a level of skill that's required in order to actually assess a client's competence. It shouldn't be assumed, for example, that patients with a mental illness aren't able to make decisions with respect to their healthcare. There might well be some situations and some decisions where they're quite competent to make decisions in relation to their own treatment. There's also the issue of the complexity of the decision making required. So, you know, how do we actually take note of people's language difficulties or their competence, not their competence, their aptitude more generally? Maybe they just don't have the cognition to be able to understand the information which is being presented to them. So it's interesting that most case law in this area is actually about a patient's refusal to consent to treatment and whether in fact they're competent to refuse to actually engage in intervention. And obviously those who bring the action to the courts argue that the patient's not competent to make the decision in those circumstances, whether it be actually because of exposure to pain or suffering or anxiety or stress or duress or coercion or whatever the circumstances might be. At this point, I draw your attention to the fact that there is a distinction between competence and capacity, and I'd ask you to take note of that in your readings because it does become important. There are lots of reasons why there might be diminished competence, and there are lots of remedies, if you like, or lots of consequences as a result of diminished competence. In a situation where a client is assessed as not being competent or loses the ability to make decisions in terms of their own life, there's one of three paths which might be taken. There's the best interests principle, there's substituted judgments, and there's advanced directives. And again, these are actually outlined in your readings for this week. The best interest standard of decision making for incompetent patients requires surrogate decision makers, such as professionals, to make decisions on the patient's behalf. It clearly relies on and is supported by the principle of beneficence, which is doing good, or non-maleficence, not doing harm. It is supposed to be patient-centred, and there is an assessment of the burdens and the benefits of the intervention. So the surrogate decision maker, usually the professional, actually then just steps in and makes the decision for the patient. However, these decisions can clearly be difficult, and there's a range of reasons why, which I'll ask you to actually consider. There's a substituted decision making, and this involves a proxy decision making, deciding for the patient based on what they believe the patient would decide. So it's next of kin, or it might actually be the court deciding based on what the person themselves might have actually said around their wishes before the event, on what the person would have liked to have happened under the circumstances. I guess the difficulty with that is proxy decisions and substituted judgment can't be made for patients who've never had competence, because you don't know, it's never been articulated. And there might also be a low level of accuracy depending upon how much information was acquired in the particular circumstances. So there's always a degree of risk that the substituted decision making or the substituted judgment isn't in fact in line with what the person would have actually wanted, because there's inaccuracies of information, or the person themselves might, given the circumstances, have changed their mind themselves. So there's a little bit of unknown with the substituted decision making. Then there's the advanced directives, which I'm sure many of you know about. That's where directions are actually given by the patient before their competence is compromised. So living wills, durable power of attorneys for healthcare are examples of those advanced directives, and they are articulated, they are written, and they are clear as to what the person would want in circumstances, usually through a living will, where it's quite clear then what the person actually wants to have happened, wants to happen to in certain decisions with respect to their healthcare, such as the do not resuscitate directives. Thank you, students. That brings today's topic to an end.